Welcome to This Explainer. Today, we're going on a totally fascinating, structured journey right into the world of pediatrics. We're going to cover everything from the miraculous mechanics of a baby's very first breaths in the delivery room, all the way up to solving the kinds of highly complex clinical puzzles that medical professionals face every single day. So, if you're looking for a clear, engaging breakdown of pediatric care, you are definitely in the right place. Let's dive in. Here's our roadmap for today's explainer. First, the crucial first minutes of life. Next, the rules of child development. Then we'll be decoding blood disorders, moving into congenital heart defects, and finishing up with the holistic nursing assessment. All right, Section 1, the crucial first minutes, newborn reactivity and biomechanics. So when you look at the timeline of how a newborn adapts right after birth, this really amazing pattern pops up. Within the first 30 to 60 minutes, the baby hits what we call the first period of reactivity. They're super active, and crucially, their suck reflex is at its absolute strongest. This is the golden window, guys. This is exactly why skin-to-skin contact and the initiation of breastfeeding have to happen right here. It builds the whole foundation for bonding and nutrition. After that, they crash into a deep sleep, the period of inactivity for a couple of hours, before waking up again for a second reactive phase, where their heart and respiratory rates shoot up. Now, moving from their internal physiology to how they actually move, you'll often see newborns making these really sudden, jerky, uncoordinated arm movements. Sometimes parents panic, thinking, it's a neurological issue. But honestly, it's just physics. Inside the womb, the amniotic fluid gave them buoyancy. Their arms basically floated. Once they're born, that buoyancy is gone and gravity completely takes over. The baby is suddenly feeling the true weight of their own limbs for the very first time, and they just have to learn how to manage it. Moving right along to Section 2, Rules of Child Development, Decoding Physical Growth. The first golden rule here is cephalocaudal development. Basically, this just means physical growth and motor control progress from the head all the way down to the toes. Think about it practically. A baby absolutely has to learn how to hold up their own neck before they can ever hope to sit upright, and they definitely have to sit before they can stand or walk. The structural integrity has to start at the top. Building off of that, the second rule is proximodistal development. This dictates that growth and control move from the center of the body outward toward the extremities. A perfect real-world example, a child is going to learn to control their shoulder to lift their entire arm long before they develop the fine motor skills in their tiny fingers to grip a pen. Core stability always precedes extremity control. All right, Section 3, Decoding Blood Disorders, Hemophilia, Sickle Cell, and Anemia. Before I hit you with the clinical data, I want to throw this question right at you. It's a huge trap in medical exams. When you hear hemophilia, do you classify it as a bleeding disorder or a clotting disorder? Well, here's the crucial answer. It is fundamentally a clotting disorder. That's a huge distinction. If you were to check a hemophilia patient's bleeding time or platelet count, the results would actually come back completely normal because their platelets are doing their job just fine. The real issue is the abnormal prolongation of the partial thromboplastin time, or PTT. This happens because the disease is driven by a lack of specific clotting factors in the intrinsic pathway, factors 8, 9, 11, and 12 to be exact. Without those, the blood just literally cannot form a proper clot. Now, shifting over to sickle cell anemia. Managing this one requires some strict behavioral rules, like why are patients told to avoid high altitudes or unpressurized flights? Simply because high altitude means lower oxygen, hypoxia, and a lack of oxygen is the exact trigger that causes those red blood cells to sickle or warp in shape. On top of that, maintaining heavy hydration is totally non-negotiable. If a patient gets dehydrated, their blood viscosity increases, meaning it gets thicker, and that dramatically spikes the risk of those sickled cells clumping up and causing a super painful obstruction in the small blood vessels. Which brings us to a really tricky diagnostic puzzle. Iron deficiency anemia and thalassemia can look nearly identical under a standard microscope. In both cases, the red blood cells look small and pale, which is technically called microcytic and hypochromic. But there is a vital difference you need to know. Iron deficiency presents with a low red blood cell count, whereas thalassemia presents with a normal red blood cell count. To tell them apart fast, clinicians use a really clever math shortcut. They divide the mean corpuscular volume, or MCV, by the red blood cell count. Because the RBC count is low in iron deficiency anemia, dividing by that smaller number gives you a much higher ratio, like the 66% outcome shown here. But in thalassemia, where the RBC count is normal, you're dividing by a larger number, which gives you a lower ratio, like 50%. It's just a brilliant, quick way to separate two very similar-looking conditions. To combat anemia on a massive scale, the Ministry of Health and Family Welfare launched the WIFS program, or Weekly Iron Folic Acid Supplementation. It targets youth aged 10 to 19, delivering a specific dose of 60 milligrams of iron and 500 micrograms of folic acid. But you've got to notice the key detail under demographics here. This program is deliberately not just for students in regular schools. It is explicitly designed to reach out-of-school girls too, making sure absolutely no vulnerable demographic falls through the cracks. Section 4, Congenital Heart Defects, Atrial Septal Defects. Picture this clinical scenario for a second. You're doing a routine physical exam on a 1-year-old child, and your stethoscope picks up a very distinct heart murmur. What exact mechanical failure is going on inside that tiny heart to make that sound? Well, here's the step-by-step mechanical breakdown. Because there's a defect, literally a hole between the heart's upper chambers, blood shifts abnormally. The left atrium operates at a much higher pressure than the right atrium, so the blood gets forcefully shoved from left to right. It's actually this turbulent, chaotic flow of blood pushing through the defect that creates that murmur you're hearing, and since these defects rarely just close on their own, the recommendation is a surgical closure using a patch, usually done before the kid even reaches school age. And that brings us to our final section, number 5, the Holistic Nursing Assessment, Patient Advocacy and Safety. This is really where medical professionals transition from just treating biological symptoms to acting as fierce patient advocates. When a nurse suspects child abuse, strict, impartial protocols have to be followed to keep the child safe and get accurate info. First up, parent interviews always have to happen in a secure, private setting, never out in a chaotic, loud emergency room. The approach has to be direct, highly honest, and super attentive. The trick is to ask open-ended questions so the parents can explain without you leading them. And crucially, a nurse must never act like an interrogator. Asking a parent what they could have done differently is accusatory, it shuts down the whole conversation, and it completely breaches protocol. Through those really careful, structured interviews, clinicians might spot an overly disciplined, intimidating, or controlling home environment. In medical terms, we don't frame this as a personal judgment, but as a specific clinical observation. The formal nursing diagnosis here would be altered family processes related to physical control by a parent. Keeping it objective like this lets the healthcare team step in and offer the right support systems without getting derailed. Which really brings us to the ultimate takeaway of this explainer. From the physics of a newborn's first clumsy movements to the heavy emotional intelligence you need to diagnose a fractured family dynamic, pediatric care is incredibly demanding. So, the question I want to leave you with today is this. As you build up your understanding of the physiological and holistic needs of children, are you truly prepared to look beyond those immediate symptoms on a chart and bravely see the whole patient? Thank you so much for joining me, and keep learning.